Good morning. Today I'm going to speak about the clinical applications of the acceleration techniques that are, last speaker really nicely presented the technical aspects about. So I would like to disclose that University of Wisconsin Department of Radiology receives research support from GE Healthcare. Now, MRI protocols for evaluating joints in clinical practice typically consist of two-dimensional fast-spin echo sequences repeated in multiple planes. While these two-dimensional fast-spin echo sequences have high in-plane resolution and excellent tissue contrast for evaluating all joint structures, they typically need to be repeated in multiple planes, which results in about 4 to 5 individual scans to be performed. This results in relatively long MRI examination times, which are inconvenient and uncomfortable for patients, and reduces the clinical efficiency of MRI scanners. Over the last several years, there has been much recent effort in order to develop various methods to accelerate musculoskeletal MRI. And for the next 35 minutes or so, I would like to discuss the literature regarding these different techniques. And these techniques include efficient K-space trajectories, parallel imaging, isotropic resolution imaging, compressed sensing K-space undersampling, and the recently described T2 shuffling method. I'd like to first discuss efficient K-space trajectories. Most MRI pulse sequences used to evaluate joints, both two-dimensional fast-spin echo sequences and three-dimensional sequences, use Cartesian-based K-space trajectories. Now, there are other types of methods to fill K-space, including radial, cone, and spiral K-space trajectories, which provide more efficient acquisition of image data. These efficient K-space trajectories have been used to accelerate morphologic three-dimensional joint imaging. At University of Wisconsin, we combined a radial K-space trajectory with a fast-suppressed steady-state free precession sequence in order to evaluate the knee joint. Now, this radial trajectory doubles the data acquisition efficiency compared to Cartesian methods. Thus, when using the radial steady-state free precession sequence, we were able to acquire images with the knee with 0.4 millimeter isotropic resolution in 5-minute scan time. In order for other three-dimensional sequences to acquire similar 0.4 millimeter isotropic resolution images, it requires between 7 to as long as more than 12-minute acquisition times. Now, the improved acquisition of image data can also be used to basically create high-resolution images, which is 0.3 millimeter isotropic resolution, and still a clinically feasible 8-minute scan time. And as you can see here, these images look very nice, and high resolution is especially very valuable for evaluating articular cartilage. Now, our group tried to investigate whether or not this radial steady-state free precession sequence could be used to provide comprehensive joint assessment. For the most part, the sequence was able to detect knee joint pathology, as in this patient with a posterior horn medial meniscus tear and this patient with an anterior cruciate ligament tear. However, despite being a very fluid-sensitive sequence, the steady-state free precession tissue contrast was just not as optimal as the fast-spin echo tissue contrast that we typically use in clinical practice. And this case nicely illustrates this fact. Here's a patient with a surgically confirmed posterior root medial meniscus tear, which can be nicely seen on the two-dimensional T2-weighted fast-spin echo image, but cannot be seen on the corresponding radial steady-state free precession image due to decreased tissue contrast. Nevertheless, this radial steady-state free precession sequence is very nice for evaluating articular cartilage. The image on the left, it's a 0.3 millimeter isotropic resolution image. Note this superficial cartilage lesion on the femoral trochlea is nicely visualized. On the corresponding fat-suppressed T2-weighted fast-spin echo image, it is less conspicuous due to lower in-plane spatial resolution. Now, efficient K-space trajectories have also been used to accelerate quantitative three-dimensional joint imaging. And these efficient K-space trajectories are primarily used to help accelerate low signal-to-noise ratio quantitative imaging, including sodium imaging and ultra-short echo time imaging, typically using cone and spiral K-space trajectories. Gary Gold's group from Stanford described the use of a cone K-space trajectory to accelerate sodium imaging. Using this technique, he was able to acquire 1.3 millimeter by 1.3 millimeter by 3 millimeter voxel size sodium images of the knee joint in a 21-minute scan time. This slide shows applications of this cone sodium imaging in an asymptomatic subject 10 years after anterior cruciate ligament injury. Note on the morphologic spoiled gradient recall echo scan on the left, there is normal appearing cartilage on the femoral trochlea. However, on the sodium image on the right, note the focal area of decreased sodium concentration correlating with areas of proteoglycan loss due to early cartilage degeneration due to prior knee trauma. Dr. Constance True Group from Stanford used a spiral case-based trajectory in order to accelerate a ultra-short echo time T2 star sequence for single component T2 star mapping of articular cartilage. Using this technique, they were able to acquire 0.6 millimeter by 0.6 millimeter by 2 millimeter voxel size T2 star maps of the knee joint in a 22-minute scan time. And Dr. Chu's group performed many nice studies using this sequence, including one in which they followed patients with anterior cruciate ligament injury over time. And this slide nicely shows a focal area on the posterior weight-bearing surface of the medial femoral condyle, which has an increased T2 star value when compared to a control subject due to acute cartilage injury. Now, on the one-year follow-up in the same patient, note how the injury of cartilage was healed with the T2 star relaxation time decreasing to a normal value, similar to the control subject. Now, our group recently has used a cone case-based trajectory provided by GE Healthcare to perform bicomponent ultra-short echo time T2 star mapping of tendon. Using this technique, we were able to acquire 0.6 millimeter by 0.6 millimeter by 3 millimeter voxel size bicomponent T2 star maps of the patellar tendon in an 18-minute scan time. Now, using this bicomponent technique, we were able to assess the individual water components of the tendon and create parametric maps showing the T2 relaxation time of both the fast relaxing macromolecular bound water component and the slow relaxing bulk water component, as well as measure the fraction of the fast relaxing water component. This slide shows a clinical application of this technique. This is a patient with patellar tendinopathy. Note in the proximal patellar tendon, there's a focal area of decreased fraction of the macromolecular bound fast relaxing water component with an increase in the T2 relaxation time of this fast water component when compared to the healthy volunteer. Now I would like to discuss another method, parallel imaging for accelerating scan time, very commonly used in musculoskeletal MRI. And like our last speaker nicely illustrated, parallel imaging takes advantage of the spatial information inherent in phase array radiofrequency coils. And the number of sampled case-based lines is reduced by an acceleration factor R, which leads to the reduction in acquisition time. Now, using parallel imaging to accelerate musculoskeletal MRI results in a loss in signal-to-noise ratio, with the signal-to-noise ratio of the parallel imaging scan equal to signal-to-noise ratio of the baseline scan divided by the product of the square root of the acceleration factor and a spatially dependent term called the geometry factor. Now, this basically this loss in SNR caused by the parallel imaging acceleration is typically offset by use of high field strength 3T scanners and dedicated multi-channel phase array extremity coils. This slide nicely shows the influence of parallel imaging acceleration. Here's a patient who was imaged with a fat-suppressed spoiled gradient recall echo scan. And notice with the parallel imaging, the cartilage is a lot more noisy than the baseline scan due to the loss in signal-to-noise ratio. Now, parallel imaging techniques have been used to accelerate morphologic three-dimensional cartilage imaging, and there is a wide variety of different MRI techniques that have been used with parallel imaging in order to decrease scan time, including spoiled gradient recall echo sequences, dual echo in the steady state, gradient recall echo acquired in the steady state free precession, driven equilibrium Fourier transform in three-dimensional fast-spin echo sequences. Scan times of all these three-dimensional sequences significantly reduced with parallel imaging acceleration while maintaining adequate image quality. Now, three-dimensional cartilage imaging sequences have improved cartilage signal-to-noise ratio in contrast to noise ratio efficiency and higher in-plane spatial resolution in thinner slices than two-dimensional fast-spin echo sequences typically used to evaluate articular cartilage. Now, does these theoretical advantages necessarily translate into improved diagnostic performances? Well, multiple studies with surgical correlation have compared various three-dimensional cartilage imaging sequences with conventional two-dimensional fast-spin echo sequences for evaluating the articular cartilage on both 1.5T and 3T scanners. And to this point in time, no study has documented a statistically significant improvement in diagnostic performance when using the three-dimensional cartilage imaging sequences. Now, parallel imaging has also been used to accelerate quantitative three-dimensional cartilage imaging sequences. Dr. Robbie Righetti's group at NYU described the use of parallel imaging acceleration to accelerate a T1 mapping sequence for use in delayed gadolinium-enhanced MRI imaging. Using the parallel imaging acceleration, they were able to acquire 0.7 millimeter isotropic voxel size T1 maps of articular cartilage with comparable cartilage T1 values to baseline scans with a 50% reduction in scan time. Now, Dr. Majumdar's research group at UCSF has used parallel imaging to accelerate T2 and T1 row cartilage imaging and to create T2 and T1 row cartilage maps with 0.5 millimeter by 1 millimeter by 3 millimeter voxel size with comparable cartilage T2 and T1 row values to baseline scans with a 50% reduction in scan time. Now, the UCSF research group has used these accelerated T2 and T1 row mapping sequence in a large number of excellent osteoarthritis research studies over the last decade on both the knee joint and hip joint. And this slide is from one of their studies in which they compared T1 row imaging of cartilage at various time points in patients with osteoarthritis. And note, here on the 2-year follow-up, there is increased T1 row relaxation time in the central and posterior weight-bearing surfaces of the medial femoral condyle at a 2-year follow-up in this patient with osteoarthritis when compared to the baseline scan, indicating worsening cartilage degeneration over time. Now, parallel imaging techniques have also been used to create these combined three-dimensional morphologic and quantitative cartilage imaging methods in which the technique acquires both a morphologic scan in order to evaluate cartilage morphology and simultaneously creates a quantitative parametric map in order to evaluate cartilage composition and microstructure. Dr. Siegfried Tradnick's group in Vienna described the use of a DES-based T2 mapping sequence to evaluate the articular cartilage of the knee joint. And Dr. Brian Hargreaves' group at Stanford used a DES-based method in order to create T2 maps and diffusion maps at the same acquisition time. And Dr. Gary Gold's group from also from Stanford developed a fast-spin echo-based method to create either T2 maps and T1 row maps. This slide illustrates potential clinical applications of this combined three-dimensional morphologic and quantitative cartilage imaging. Here's a patient with a acute knee injury following trauma, and we performed this combined imaging on this individual. Note on the three-dimensional fast-spin echo source image, the cartilage on the lateral femoral condyle overlying an area of bone marrow edema appears relatively normal, at least as far as its morphology. However, on the simultaneously acquired T1 row map, note the significant increase in the T1 row relaxation time in this area of cartilage, indicating acute cartilage injury. Now, parallel imaging techniques have also been used to accelerate morphologic two-dimensional joint imaging. Now, the next series of 4 slides, I'd like to illustrate the ability of using parallel imaging to accelerate two-dimensional joint imaging by a factor of 50%. Here's a accelerated axial fat-suppressed T2-weighted fast-spin echo image, an intermediate-weighted fast-spin echo image, a sagittal fat-suppressed T2-weighted fast-spin echo image, and a coronal fat-suppressed intermediate-weighted fast-spin echo image. Now, our standard routine knee joint MRI protocol at University of Wisconsin consists of all those 4 scans that we showed you with a total scan time of a little bit more than 12 minutes. Now, using this accelerated knee protocol, we could acquire the same tissue contrast two-dimensional fast-spin echo images in a total scan time of merely 6 minutes. This scan time is short enough in order to basically put your routine MRI examination of the knee in a 15-minute time slot and allow some time to position the patient and repeat scans as necessary. Now, obviously, the image quality of this accelerated sequence is not nearly as good as the image quality of the standard routine MRI protocol, but maybe good is good enough. A lot of times, radiologists get these state-of-the-art 3T scanners, and they just basically use the technology in order to optimize, maximize image quality so that they don't detect joint pathology. And there's few groups that are really going to try to accelerate these MRI protocols with the fear of decreasing their diagnostic performance for detecting joint pathology. Now, this really nice recently published study out of both Cleveland Clinic and NYU described the use of a fast 5-minute accelerated two-dimensional fast-spin echo protocol for evaluating the shoulder joint. And two-dimensional fast-spin echo sequences in this study of the shoulder were performed with and without parallel imaging acceleration on 200 patients on either a 1.5T or 3T scanner. Now, use of the parallel imaging acceleration reduced scan time from 16 minutes to as short as 5 minutes. Now, the study found that inter-protocol reader agreement for determining the presence or absence of joint pathology was equal to the inter-reader agreement of the standard MRI, indicating that the accelerated MRI protocol yielded similar clinical information regarding all joint structures than the standard MRI protocol. In addition, the accelerated and standard MRI protocols had similar diagnostic performance for detecting joint pathology in 50 patients with surgical correlation. This was probably the first paper, at least I'm aware of, that actually tried to, kind of image the joint with an accelerated protocol, and it was found to yield similar diagnostic performance. Here's an image from Dr. Subhas's study in which you can see a focal interstitial tear of the supraspinatus tendon equally well in both the standard and the accelerated coronal fat-suppressed T2-weighted fast-spin echo images. The next technique I'd like to talk about to accelerate musculoskeletal MRI is isotropic resolution imaging. Now, isotropic resolution imaging has been made possible by the recent development of three-dimensional fast-spin echo sequences, which have the same tissue contrast as the two-dimensional fast-spin echo sequences we've been using in musculoskeletal radiology for decades. Now, these three-dimensional fast-spin echo sequences are combined with parallel imaging acceleration and are performed on high field strength scanners and with the use of multi-channel coils in order to maintain adequate signal-to-noise ratio. Now, three-dimensional fast-spin echo sequences are now commercially available on most MRI vendor platforms. Now, the advantages of these three-dimensional fast-spin echo sequences is that you could acquire an image in a single plane and then reformat images in other planes using the volumetric source data, eliminating the need to repeat sequences with identical tissue contrast in multiple planes. Now, multiple studies with surgical correlation have compared the diagnostic performance of three-dimensional fast-spin echo sequences and two-dimensional fast-spin echo sequences for evaluating knee joint pathology. And most studies reported statistically non-significant or similar diagnostic performances of the two-dimensional and three-dimensional sequences for detecting surgically confirmed cartilage lesions, meniscus tears, and ligament tears. Now, when we look at the imaging parameters of these three-dimensional fast-spin echo sequences used in these studies, in order to maintain clinically feasible scan times, these sequences use either relatively low isotropic resolution and long echo train lengths, which may degrade image quality due to image blurring, or use anisotropic resolution voxel size, which may decrease and degrade the image quality of the multiplanar reformat images. This slide shows the potential effects of low isotropic resolution and long echo train lengths on the detection of knee joint pathology. Here's a patient with a surgically confirmed posterior horn of the medial meniscus tear, which is nicely seen on the two-dimensional fast-spin echo image with intermediate weighted contrast, but is much more difficult to visualize on the corresponding three-dimensional fast-spin echo image due to greater image blurring. Here's another patient with a surgically confirmed tear of the posterior root of the lateral meniscus on the coronal intermediate weighted two-dimensional fast-spin echo image. Note the signal abnormality in the undersurface of the posterior root. This signal abnormality cannot be visualized on the corresponding three-dimensional fast-spin echo image due to increased image blurring. Now, the next two sets of slides kind of illustrate the potential disadvantages of using near-isotropic, anisotropic voxel volume. Here's an image on the left. It's a axial reformat image from a three-dimensional fast-spin echo sequence acquired with 0.7 millimeter pure isotropic resolution. Note the nice image quality of the reformat images with the smooth, well-delineated articular surface of the lateral patellar facet. The image on the right is a three-dimensional fast-spin echo sequence, an axial reformat images created from a volumetric source that had an isotropic resolution of 0.4 millimeter by 0.4 millimeter by 1 millimeter voxel size. And noted the slight degradation of image quality with much greater blurring of the articular surface on the reformat images. Now, a lot of times this degradation of image quality on the reformat images using anisotropic voxel volume can interfere with the detection of knee joint pathology on this patient with a surgically confirmed deep partial thickness cartilage fissure on the lateral patellar facet, which can be nicely visualized on the axial reformat image from the 0.7 millimeter isotropic source data, but is much more difficult, if not at all, visualized on the corresponding axial reformat image from the three-dimensional fast-spin echo sequence using anisotropic voxel size. Now, the ultimate goal of three-dimensional fast-spin echo imaging is to acquire images with high isotropic resolution and high signal-to-noise ratio while maintaining relatively short echo train lengths and short acquisition times. And even using state-of-the-art 3T scanners, it is very difficult to achieve this ultimate goal in clinically feasible scan times. Now, the next technique I'd like to discuss for acceleration of musculoskeletal MRI is compressed sensing. Now, compressed sensing utilizes case-space undersampling in order to accelerate scan time. Compressed sensing has been used to accelerate morphologic three-dimensional joint imaging. And what happens is that a three-dimensional fast-spin echo sequence is accelerated both using parallel imaging and compressed sensing acceleration. And then, obviously, we use the high-field strength scanners and the multi-jointed coils in order to maintain the adequate signal-to-noise ratio using the acceleration methods. Now, compressed sensing three-dimensional fast-spin echo sequences are now available, at least for research purposes, on both GE Healthcare and Siemens Medical Systems MRI platforms. A nice paper by Fritz and Associates described the use of compressed sensing space on a Siemens Medical System 3T scanner. And in this study, they compared compressed sensing space with two-dimensional fast-spin echo sequences of the knee in 5 healthy volunteers in 15 patients with knee pain. The study found that the compressed sensing space in two-dimensional fast-spin echo sequences had similar signal-to-noise ratio for all tissues except brighter fluid for the two-dimensional fast-spin echo sequence. The compressed sensing space in two-dimensional fast-spin echo sequences also had similar ratings for image quality and moderate to excellent agreement for assessing joint structures. And both techniques also had similar diagnostic performance for detecting non-surgically confirmed meniscal tears in their patients with knee pain. We at University of Wisconsin performed a study along with our collaborators from GE Healthcare in which we acquired cube scans using the same imaging parameters of the knee with and without compressed sensing on 2 groups of subjects. One group of subjects consisted of 10 healthy volunteers in which the compressed sensing and non-compressed sensing scans were performed twice for evaluation of signal-to-noise ratio using the addition-subtraction method, which is recommended for sequences using parallel imaging in order to best evaluate signal-to-noise ratio, and also to assess spatially variant noise behavior, which has been a technique previously used in order to assess signal-to-noise ratio when using compressed sensing acceleration. We also performed cube scans with and without compressed sensing once on the knees of 50 symptomatic patients to evaluate image quality and diagnostic performance. In our study, we found that compressed sensing cube and cube had similar signal-to-noise ratio for all tissues with no noise amplification with use of the compressed sensing acceleration method. In addition, compressed sensing cube and cube had perfect to near perfect agreement for detecting knee joint pathology. In addition, both sequences had similar diagnostic performance for detecting 60 cartilage lesions, 4 anterior cruciate ligament tears, 20 meniscus tears, and 4 intra-articular bodies confirmed at surgery. However, we did notice that compressed sensing cube was graded lower than cube for many patients for clarity of joint structures and conspicuity of joint pathology. Now, in order to further investigate this lower clarity of joint structures and conspicuity of joint pathology, we performed the cube and compressed sense cube scans on an American College of Radiology Phantom in order to compare the image blurring. This slide compares cube and compressed sensing cube images on a high contrast 0.9 millimeter resolution Phantom. Note the greater image blurring on the compressed sense cube image when compared to the cube image. This slide shows comparison of images on the low contrast resolution Phantom. Note even more blurring of the compressed sense cube images when compared to the cube images. And this image blurring is so extensive that it's very difficult to even distinguish the individual dots, which are separated by 0.9 millimeters apart. Now, for the most part, cube and compressed sense cube had almost identical visualization of knee joint pathology as seen in this patient with an anterior cruciate ligament tear and this posterior horn medial meniscus tear. However, the next two slides illustrate potential disadvantages of the compressed sense cube sequence for evaluating low contrast structures such as superficial cartilage lesions. Here's a patient with a surgically confirmed superficial partial thickness cartilage lesion on the medial femoral condyle. Can be nicely seen on the cube image, but much more difficult to see on the compressed sense cube image due to increased image blurring. Another patient with a surgically confirmed cartilage fissure on the posterior weight-bearing surface of the lateral femoral condyle. Note this low signal intensity cartilage fissure nicely visualized on the cube image, but not visualized on all on the compressed sense cube image due to greater image blurring. Now, despite the slight greater image blurring, especially when evaluating low contrast structures, the use of compressed sensing acceleration of three-dimensional fast-band echo sequences allows these really high-quality three-dimensional fast-band echo sequences with adequate signal-to-noise ratio to be acquired with 0.5 millimeter isotropic resolution using a relatively short 40 echo train length while maintaining a clinically feasible 5-minute, 30-second scan time. So it helped us achieve our ultimate goal of three-dimensional fast-band echo imaging. Now, compressed sensing acceleration has also been used for metal reduction imaging. In two nice papers, one by Fritz and Associate and another by Tazo and Associates, compared a STIR CMAC and an intermediate weighted CMAC sequence respectively with and without compressed sensing for evaluating patients with hip prostheses. And both studies showed that the compressed sensing CMAC and CMAC sequences showed similar image quality and conspicuity of joint pathology. Here's some images from the two papers in which we nicely see image quality almost looks identical on the accelerated and standard STIR scans and the accelerated intermediate weighted and standard intermediate weighted scans. Almost identical image quality, but with a significant reduction in scan time when using the compressed sense acceleration. Now, compressed sensing acceleration has also been used to accelerate quantitative cartilage imaging. Dr. Rigatti's group at NYU used compressed sensing acceleration to accelerate sodium imaging, and they were able to acquire these sodium images of the knee with 2 millimeter isotropic voxel size, with comparable cartilage sodium values to baseline scans, with a 50% reduction in scan time. Dr. Majumdar's group at UCSF described acceleration of T1 row cartilage imaging using compressed sensing. And they were able to acquire 0.7 millimeter by 1 millimeter by 4 millimeter voxel size T1 row maps of the knee with comparable cartilage T1 row values to baseline scan with a 50% reduction in scan time. So the last technique I want to talk about in which musculoskeletal MRI is accelerated is a technique called T2 shuffling, which is described by Dr. Venzinawala from Stanford University. T2 shuffling is a three-dimensional fast-band echo variant combining compressed sensing-based reconstruction with multiple image contrasts. Now, acquisition randomizes echo train view ordering and resamples positions in K-space at multiple echo times to compensate for T2 decay, thereby reducing image blurring when compared to conventional three-dimensional fast-spin echo sequences. In addition, the acquisition simultaneously produces isotropic resolution images corresponding to each echo time with multiple tissue contrasts. Now, what's really neat about this T2 shuffling technique is that not only can it acquire isotropic resolution images which can be reformatted in any plane following a single acquisition, but it could also acquire simultaneously images with different tissue contrasts. For example, on this slide, we could show there's a proton density weighted image with from reconstructing with an echo time of 20 milliseconds, and the same data set can be used to produce a heavily T2 weighted image with a echo time of 80 milliseconds. So Dr. Venzinwala's group performed a study in which they compared T2 shuffling with two-dimensional fast-spin echo sequences for evaluating the knee in 28 pediatric patients, and they found that the T2 shuffling and two-dimensional fast-spin echo sequences had high agreement for detecting joint pathology and graded similar for visualization of all joint structures. Here's an image from their paper, which nicely shows a free-edge tear of the body of the medial meniscus on a proton density-weighted T2 shuffling image, intermediate-weighted T2 shuffling image, and a heavily T2-weighted T2 shuffling image, which has a similar appearance of the meniscal tear as this conventional T2-weighted two-dimensional fast-spin echo image. I thank you for your attention.